We'll talk about asthma, especially asthma in children. As we know, asthma is a type 1 hypersensitivity disorder, if this is a topic, right? If this is a topic, asthma. Type 1 hypersensitivity disorder. So, in the bulge form our 2, 3, and 4, again, this is type 1. So asthma is a chronic airway inflammatory disease. So there is inflammation. The involved is the airway, especially the bronchiole and the bronchi. And it is chronic, leading to remodeling of the basement membrane of the airway. So there will be thickening after all. Then there is activation of the mast cells, leading to these three unique pathophysiologic happenings or events in the airway. Number one, we have bronchoconstriction. Then we have microvascular leakage with plasma exudation. So basically, there is bronchoconstriction here. Because of the plasma leakage, there is mucus secretion, or lots of mucus secretions. And remember the inflammation. So those are the three pathophysiologic events, no? Again, inflammation. Number two is there are lots of mucus, hypersecretion, because also of the hyperplasia of the mucus glands in the airway. And third is bronchoconstriction. So this is the very dangerous thing, no? Because there is bronchoconstriction, this could lead to airway obstruction, leading to the manifestation of wheezing. And eventually, that wheezing will become absent breath sound if that is already severe. So basically, the management for asthma is with the use of primarily bronchodilator. Then we have also a corticosteroid. So again, primarily we have bronchodilator, then we have also a corticosteroids. So later on, we'll be giving you the algorithm on how to get these medications. So basically, our nursing care here is to provide the or give or administer the bronchodilator prior to corticosteroids. So the 3B prior to C. Then you could also attach oxygen to our patient, auto inhalation via nasal prong. Then position the patient on whichever position he or she is comfortable with. Commonly, if the distress is severe, you could have an orthopneic position, or we could have a head of bed elevated. So basically, our medications are given, could be via inhalation, could be PO or per oram oral, and we have also parenteral. Sa examples, inhalation, we have either bronchodilator or corticosteroids. We have SABA or short-acting beta-adrenergic, LABA, long-acting beta-adrenergic, your corticosteroids, budesonide example, salbutamol for your SABA, salmeterol for the LABA or formoterol. Then for oral, we have oral salbutamol. We have your theophylline. Parenteral, we have your aminophylline. Yes. So basically, the route of choice is via inhalation. That puff things, yes. And sometimes nebulization. So via inhalation, we have the following delivery devices. Includes pressurized meter dose inhalers, your PMDI, that uses a propellant in the form of HFA. Then for better result or effect, we used up a spacer chamber. This decreases the amount of drug deposited in the oropharynx when using the PMDIs. So that's why there is more of the drug being delivered via the lungs rather than via the oropharynx that could be administered through the stomach, no? Kung without the spacer chamber. By the way, it could be delivered also going to the lungs, but in just a small bioavailability because it passes through the liver, in which it will be reduced. It will be reduced, no, in the liver cost effect. So other forms of delivery devices, we have here the dry powder inhalers that delivers fine powder by air turbulence on inhalation. Then we have also your nebulizers, which delivers higher doses compared to PMDIs. So that's why in emergency situations, in ER, or even in ward, we use the nebulization technique because this deliver higher doses. This can be inspired during tidal breathing. This is useful in exacerbations and severe airway obstruction. So our responsibility here as nurses, when we are nebulizing patients, we shouldn't do it in the hallway. We should do it somewhere private. Remember that your patient is coughing and your patient has a lot of mucus. We should be cautious with our respiratory droplet precautions, which is 3 feet, di ba? 3 feet distance from the other. So we need to be cautious on that. We are using nebulization technique. We have also the oral route. For example, salbutamol PO. We have also your theophylline PO. Doxycycline. Yes. The oral route has higher dose required to achieve the same effect as that of the inhaled dose with a ratio of 20:1. Much better your inhalation. If there is a choice, the inhaled route is always the preferable one. So for our bronchodilator as our first line drug of choice for asthma, we have this, especially for emergency situations, beta-2 adrenergic agonist. This will be our reliever of choice, no? Reliever of choice during emergency situations because this is short-acting. With a duration of action of 3 to 4 hours, again, bronchodilators are of choice in severe acute asthma. This is convenient to use, easy to use. The onset is rapid without significant systemic side effects. Examples of our beta-2 adrenergic agonist, we have albuterol, or we know this as salbutamol, or we could have levalbuterol, metaproterenol, terbutaline, probuterol, phenoterol, tiobuterol, and rimiterol. All. And we have also a long-acting inhaled beta-2 agonist for during more than 12 hours for salmeterol, formoterol, and aformoterol. And for more than 24 hours, this is usually given once a day. Indacaterol, vilanterol, and dior, olodaterol, olo, vela, enda. Olo ni vela ni inday. By the way, formoterol has more rapid onset of action compared to salmeterol. That's why our controller of choice now for maintenance, not for emergency, for maintenance therapy, both controller and reliever. If the patient is at home or your client or our pedia patient is already at home, it is being recommended that salbutamol will not be used anymore. But we are using this ICS LABA. ICS LABA. So what would be our choice as ICS means your inhaled corticosteroid, and we have your LABA, long-acting beta adrenergic agonist. So our ICS LABA of choice is the budesonide formoterol. Yes, this is now the controller and reliever of choice for patients who will be going home. This will be their maintenance. Maintenance, pwede 2 times a day or once a day depending on the condition, or as a reliever. So a reliever meaning as necessary if they have the dyspnea, if they feel themselves to be dyspneic, then this would be inhaled by them. So why not salbutamol? It's because according to research, it has been found out that if salbutamol will always be used, chronically been used, it leads to resistance. So there are lots of patients who died who wasn't relieved anymore by salbutamol. So that's why the recommended reliever now is the ICS LABA in the form of budesonide formoterol. LABA is being chosen, and that is formoterol because it has a more rapid onset compared to the others. That's why it is now being used. So as nurses, we need to be cautious with the different side effects of the beta-2 agonist, no? Either short-acting or long-acting. So what are our side effects? So we have here muscle tremors. Makita mo sa banda magmumurog, that's already a side effect. It's because of the direct effect in the skeletal muscle by the beta receptors. So we have again muscle tremors. We have tachycardia, makataki ni siya. Increase atong heart rate. We have also hypokalemia. We have restlessness, hypoxemia. So other than being a relief of hypoxemia, no, because it causes bronchodilation, it has also a side effect of hypoxemia by increasing the ventilation and the perfusion mismatch. So meaning, i-increase na to ang airway entry into the lungs, but the perfusion or the blood flow towards the lungs is decreased, brought about by the beta-2 adrenergic effect. So there's vasoconstriction, to reversal of the hypoxic pulmonary vasoconstriction. So that's one of the side effects. That's one of the criticisms in our beta-2 adrenergic agonist. But somehow, this is not always happening. Rare po na siya. So we have also metabolic effects. We have increase in the free fatty acids. We have hyperglycemia, kini-increase ang glucose, increase lactic acid or lactate, and pyruvic acid or pyruvate, and increase in the insulin. By the way, these are common. These are just common. The most common side effect are your muscle tremors and tachycardia. So basically, this is how we manage our pedia patients in the primary setting. No? So patient presents with acute or subacute asthma exacerbation. So there is a severe dyspnea, and we need to classify them. So first on hand, we are assessing the patient if is it really asthma. So are risk factors available? For example, the patient has viral infection before. It's one of the risk factor because the common risk factor for asthma is viral infection. The exacerbation, yes, it's viral infection is one of the most common exacerbation of asthma. The viral infection, especially with influenza A or B. Then we need to know the severity of the exacerbation. The severity of the exacerbation, we have here mild or moderate, severe, and life-threatening. So we have 3 classification for our exacerbation. Most commonly, for mild or moderate, they will not be hospitalized. Compared to severe, they will be hospitalized, the same with life-threatening. So manifestations included under mild or moderate, we have here talks in phrases that prefers setting to lying, and somehow they are not agitated. They have increased respiratory rate. Increased respiratory rate depending on the age of the child, for an RR of commonly for pedia more than 40, no? And there is accessory muscles which is being used in the respiration, pulse rate of 100 to 120 BPM, especially for adolescents and more than 5 years old. Oxygen saturation of 90 to 95%. Then the peak expiratory flow rate of more than 50% predicted or best. For severe classification, we have here talk in words, sits hunched forwards, agitated, or respiratory rate more than 30 or 40 depending on age. Then accessory muscle sinus, pulse rate of more than 120, autosat less than 90. This is very important, no? The autosaturation. And the peak expiratory flow rate of less than or equal to 50% predicted or best. And this is the very important thing that we need to assess, no? Because these are already life-threatening signs and symptoms. That includes drowsiness, the patient is confused, and this thing, silent chest. So how do we manage this? So for mild or moderate classification, we do start treatment that includes SABA in the form of salbutamol for 4 to 10 puffs by PMDI or meter dose inhaler plus the spacer. And we need to repeat this every 20 minutes for 1 hour. Then we also give per 1 to 2 microgram per kilogram, a maximum of 40 milligrams. Then if there is an available oxygen, that is 94 to 98%. If worsening, proceed to the conditions. We need to treating, we give the SABA, inhalation. We need also to give oxygen. Then mild form, then we continue treatment with SABA as needed. Then assess response at 1 hour or earlier. If worsening, proceed again to treatment to transfer to acute care facility. Then we do our if the child, then we do our maintenance guidelines, no, for our treatment. Maintenance guideline for our treatment. We assess for discharge. Symptoms improve, not needing SABA anymore. Then the peak expiratory flow rate is improving, and that is more than 68 to 80% of the personal best or predicted for your test. And the oxygen saturation is more than 94% room air without the oxygen. You need to trial first. You do trial. Then resources at home is adequate. Then we need to arrange for discharge. Reliever continued as needed. ICS LABA as the choice. Controller, ICS LABA again for choice by PUF. Then we need to teach that to our client. Then prednisolone, if given, should be continued usually for 5 to 7 days for for adolescents and adults, then 3 to 5 days for children, then follow up within 2 to 7 days. These are our um, responsibilities, nurses, to remind them to follow up. For children, 2 days. 1 to 2 days for children. Prednisolone, ICS LABA, then follow up. During follow-up, we need to review signs and symptoms. Was there an exacerbation? Was the prednisone being continued? For reliever, reduce to as needed for our reliever, PRN. Controller, ICS LABA, same. Continue higher doses for short term for 1 to 2 weeks or long term for 3 months, depending on the background for exacerbation. Then we need to check for the risk factors. Check and correct modifiable risk factors that may have contributed to the exacerbation. The viral infection, could be the occupational hazards, could be exposure to allergy, for example. Then we need to include also the inhaler technique and whether they are adherent to it. Then refer if more than 1 to 2 exacerbations in a year to your pulmo doctors. Then we need to assess if the action plan is understood. Nurses, this is our responsibility. Was it used appropriately or does it need modification? So this is our algorithm, no, for our asthma pedia clients.